Hello, I am Kristi Maas. I'm a physician at Reproductive Care Center in Salt Lake City, and I wanted to talk to all of you today about ovarian reserve testing and aging. This is one of the most common questions patients have for me, and also one of the most commonly misunderstood factors in fertility and human reproduction. Now, individuals with eggs are born with every egg that they'll ever have, and that quality of eggs and quantity of eggs both decline with time. Not everybody's egg supply starts with the exact same number. Not everybody's egg supply decreases at the same rate. But interestingly, by the time that you're about age 25 to 30, maybe 25 to 30% of the eggs are genetically or chromosomally abnormal. By the time you're in your mid-30s, around age 35, about half of those eggs are chromosomally or genetically abnormal. And by the time you're in your 40s, over 75% of those eggs are chromosomally or genetically abnormal. And we lose the quantity of eggs as well. We've actually lost about half of our eggs before we even hit puberty. And then we're down to about 10% of our eggs left when we're in our early 30s, and single-digit % of our eggs left when we're in our early 40s. And the average age of menopause is 50 and a half. We lose the reproduction function of our eggs about 8 to 10 years before menopause, and that's due to the quality. On average, women or individuals with eggs generally ovulate 1 egg a month. And our pregnancy rates are very strongly tied to our age because that egg is more likely to be genetically normal and functional when we're 20 versus when we're 30 versus when we're 40 or when we're 50. Now, unfortunately, we don't have good tests for egg quality. The best estimate is age, unless you're going through IVF with genetic testing. And genetic testing of embryos is generally reflective of the quality of the egg, more so than the quality of the sperm. We do have ovarian reserve testing to estimate the quantity of eggs and also be able to estimate how many eggs we might be able to get with treatment and what the maximum amount may be with something like IVF. One of those tests is an ultrasound. We call that an antral follicle count. We look at both ovaries. We count the number of little black circles in the ovaries called antral follicles, which are small fluid-filled areas in the ovaries where 0 or 1 microscopic egg is evolving or trying to develop for that month. The more antral follicles you have, the greater your overall egg supply is. But this is an estimate for that month, because in fact, the ones for the next month, the next year, or even the next decade are microscopic and we can't see them on ultrasound. The eggs themselves for that month are actually microscopic, but we can see the fluid-filled area where they're developing and trying to fight it out to figure out which one is the egg of the month in that antral follicle. Naturally, we wake up about 1,000 eggs every single month, and one of them becomes that dominant follicle to be ovulated, and the other 999 die off, and we don't actually get to use them. And so our fertility treatments are aimed to rescue some of those 999 that would have otherwise have died off using medications. In this way, fertility treatment doesn't damage your ovaries, it doesn't deplete your ovarian reserve. It only rescues something that would have otherwise have died. The ovarian reserve testing helps me estimate what doses of medications, what types of medications, and what the potential of these medications are to rescue the eggs. The tests also include blood work. There's a hormone called AMH, also called MIH or MIS, that's anti-Mullerian hormone, also called Mullerian inhibiting substance or Mullerian inhibiting hormone. And this is a hormone that's released as the eggs are fighting it out, trying to figure out which one's going to win to be the egg. The more eggs you have releasing the substance, the higher the level is, and the higher your overall egg supply is. Another common hormonal assessment is something called FSH, or follicle stimulating hormone. This hormone actually fluctuates throughout a menstrual cycle. It's the primary hormone that's growing the follicle to make the dominant follicle and the egg of the mom. But it also is counterbalanced by a hormone called estradiol. So you must always draw an estradiol at the same time you're drawing an FSH to really be able to assess the FSH. The FSH number is basically a volume knob. It's telling us how much your brain has to yell at the ovary to do its job. When the ovary has good egg supply, it responds pretty readily. You don't have to yell at it much. But as the egg supply is dropping down, the volume must be turned up so your FSH levels go up to get it to do its job. Eventually, when we run out of eggs, your max volume, your FSH is through the roof, and the ovary just won't respond. And that's really the essential component of menopause. These tests can help us figure out how we treat you, but they're not definitive of fertility nor infertility. There are individuals with very low egg supply or low ovarian reserve based on our testing that are perfectly fertile. The first time sperm and egg are exposed, they get pregnant. There are individuals with very high egg supply. We see this often in PCOS that struggle to achieve pregnancy and need assistance. So don't take ovarian reserve test as the same as fertility, but both of these tend to decline with time and age. So if you're having any questions or considerations, please see a reproductive endocrinologist such as myself or the other physicians at Reproductive Care Center. We're always here for you to answer your questions, help you achieve your family building and fertility preservation goals, and we'll be with you every step of the way, explaining the tests, the results, and why we recommend what we recommend. We wish you the best. Good luck in fertility.